Manar Maamoun. She will talk about MR perfusion in neuro and head and neck imaging, our experience in Ain Shams University Specialized Hospital.
Okay, good morning. I'll talk about MR perfusion in neuro and head and neck as our experience in Shams University Specialized Hospital. Before starting, I want to get sure that you all get the idea of perfusion. Perfusion is not the same as contrast enhancement. Not every contrast enhancing lesion is a hyperperfused one. Perfusion refers to the blood flow through tissues, while contrast enhancement refers to the leaky vessels, abnormal vessels that leak contrast. Okay? So hyperfusion means that there is a lot of blood flow within the tissue. Brain perfusion has many indications. It's critical for stroke imaging. We use it for tumors, for initial diagnosis, characterization, grading, follow-up. It can guide biopsy by knowing the more hyperperfused areas within the tumor. It has a very important role in vascular malformation and the neurodegenerative diseases. In head and neck, perfusion has an important role for tissue characterization, staging of tumors, and monitoring. There are contrast-enhancing techniques and non-contrast-enhancing techniques that can be used to get perfusion images. The contrast-enhancing techniques we use in brain are the dynamic susceptibility contrast technique, which is called T2 star perfusion, and the dynamic contrast-enhanced technique, which is called K-trans perfusion or T1 permeability. And the usually acquired non-contrast-enhancing perfusion imaging is the arterial spin labeling. Starting with the contrast-enhancing perfusion, I'll start with the basic one, or the more common one, which is the dynamic susceptibility contrast technique, which uses T2 star images in a very short manner and to get time intensity curves, as I'll show later. As the contrast passes within the tissue, there is drop of signal corresponding to the contrast itself, because this is a T2 star image, a gradient image. So, as the blood flow increases or the contrast passes, there is a drop of signal. Again, the contrast passes, we start imaging before injection of the contrast. Then, with contrast passage through the tissue, there is decline in the curve because the signal intensity of the tissue decreases. Then there is a recovery. We can get different maps: cerebral blood flow, cerebral blood perfusion, mean transit time, and time to peak. This is a qualitative maps. We can evaluate qualitatively. And we can do post-processing to get a more quantitative data. We do the post-processing techniques using our workstations. I am using the manual method. I apply a region of interest on a blood vessel. Then we have different curves. I choose the most appropriate appearing curves. Then further processing show us the different color-coded maps: cerebral blood flow, perfusion, volume, and the time intensity curves. We can apply region of interest to get the time intensity curves, which represent a semi-quantitative assessment method. And furtherly, we can get quantitative data with numbers and percentages. The second contrast-enhancing method we use for perfusion is the T1 weighted image, or T1 permeability. That depends on injection of the contrast, then acquiring T1 weighted images instead of the T2 star images acquired with the T2 star perfusion. So the signal increases on time on injection of the contrast. Here is the appearance of the curve acquired from the T1 permeability study, and the different color-coded map, which is the K-trans, KEP, and VE. The most important for us is the K-trans. I'll talk about it now. An example of the K-trans map, we can perform a kind of fusion or overlap of an anatomical or conventional imaging with the perfusion for better analysis and demonstration of the enhancement pattern with perfusion to the surgeon or the referring clinician. The K-trans, which is the parameter we acquire from this study, is called the volume transfer constant. It's expressed in milliliters per minute per 100 milliliter. It represents the rate at which contrast moves from the plasma to the extracellular space. It represents how leaky the vessels are. In a similar way to normal contrast enhancement, but with contrast enhancement, the vessels are leaky and the contrast passes through tissues, but we are not assessing its timing. The K-trans, we assess how quickly the contrast leaks from the intravascular to the extravascular compartment, while the usual contrast enhancement, we assess the presence of leakage, not in a timely manner, so they are different. The K-trans depends on disruption of the blood-brain barrier, but this doesn't mean that it goes to zero in a normal tissue. It will be low value, low K-trans value, but not zero. High K-trans value is more specific than cerebral blood volume for showing how aggressive this lesion. We prefer to combine both techniques. By combining both with contrast and perfusion, high enhancement and high K-trans value usually goes with aggressive tumor like GPM. Enhancing lesion with a low K value represent a damaged tissue, like radiation necrosis. We can see enhancing lesion, but the K-trans value is low because there is no high rate of contrast leakage. The low enhancement and high K-trans is considered suspicious because the K-trans value and the perfusion can precede the changes that occur with contrast enhancement. While lesion can have strong contrast enhancement, again, but not high K-trans value, because the leakage in this case is slow. But it has enough time, so the contrast accumulates with time. It takes its contrast, but in a delayed manner, like radiation necrosis. Again, I'll talk about the difference between cerebral blood volume and K-trans. Cerebral blood volume means how many blood vessels or how wide caliber are the blood vessels within the tissue, commonly due to the angiogenesis that occur with tumors, okay? Because the tumors have stimulating factors for blood vessels, so high cerebral blood volume, which is the most important parameter to be measured in brain tumors, means that there are a lot of vessels, pipes, bringing blood to the tumor, but this doesn't mean that these vessels are leaky. There can be lots of vessels, as in low-grade gliomas, but not leaky. While K-trans, high K-trans value means that these vessels are leaky. Okay? High K-trans value occur when the blood vessel is disrupted, blood-brain barrier is disrupted, while cerebral blood volume occur when there is a large number of vessels and high density. High cerebral blood volume and high K-trans in interpretation means that there is dense vasculature and the vessels are abnormal, so leakage of contrast occur. While high cerebral blood volume with a low K-trans value means that this is a highly vascular tumor, but the blood-brain barrier is intact. That could occur with vascular malformation and low-grade gliomas with intact blood-brain barrier. Low cerebral blood volume with a high K-trans value could occur with radiation necrosis, because radiation necrosis involves breaking of the blood-brain barrier, so the vessels are leaky, but there is no angiogenesis and no increase in blood density in this area. Low cerebral blood volume and low K-trans is considered safe finding for low metabolic lesion and stable blood-brain barrier. For the importance of acquiring both techniques and to have data about K-trans and cerebral blood volume, there is a technique we use which is called split two bolus technique to acquire both perfusion techniques in the same session for the patient. This saves the patient another additional study to get the data from other exam, and also save the patient and his kidney the excess contrast. We use two bolus, starting with the T1 permeability, then T2 star. The total contrast dose is 0.1 millimole per kilogram. There are requirements for this technique to be performed correctly. First, the cannula should be a wide bore cannula, at least pink cannula for an adult, and preferably more. The preferable technique is to use injector, but it still can be done with manual injection, but with experienced personnel who know how to inject constantly and rapidly. We inject in two manners, in two bolus. The first one involves about 0.25% of the total dose, while the second one involves about, we take 75% of the rest of the dose. We start with T1 images, and I say why we use this method. We inject a small dose with a moderate injection rate, just 2 to 3 milliliters per second. This technique takes about 5 minutes, okay? Then we should have a pause or a delay for 5 to 7 minutes. Of course, we do not leave the patient on his own, and we use this delay to acquire other sequences like T2 images and DWI. Okay, then we perform the second bolus injection, the T2 star, but this time it's performed with a high injection rate by 4 to 5 milliliters per second, and we acquire the T2 star images and performing post-processing. Why we perform post techniques? To get the benefits of both and to be more reliable and consistent, to have consistent data. High cerebral blood volume with a high K-trans usually goes with aggressive tumor with angiogenesis and blood-brain barrier disruption, while low cerebral blood volume and high K-trans likely represent leaky vessels without significant new vascularity. So it could be necrosis or other else rather than tumors. Okay, we should start with T1 perfusion and not T2 star perfusion, because the small bolus we give in the start do not disrupt the T2 star perfusion. Okay, T2 star perfusion not disrupted by the 25% of the dose we inject first, while the reverse. If we started with the dynamic susceptibility imaging, excess gadolinium will be present in the extracellular space. So when we perform the dynamic contrast enhancing T1 permeability, there is no pre-contrast baseline. So the curves will be flattened and disrupted and no reliable data. Again, summary, dynamic, we start with the dynamic contrast enhancing technique, which is the T1 permeability by injecting quarter of the dose. Then we perform the dynamic susceptibility imaging with a delay of 5 to 7 minutes in between. We use this period to acquire other sequences that are not affected by contrast injection. And we acquire, by this technique, the data of cerebral blood volume, cerebral blood flow, that represent the density and size of vessels, while the other technique, we acquire the K-trans value, how leaky. Another technique is the arterial spin labeling, which is the non-perfusion technique. In this technique, the MRI machine uses the patient's own blood as a contrast agent. The RF pulse is applied at the level of the start of the neck to saturate the arterial blood before entering the brain tissue. Then, after a short delay, the labeled blood flow to the brain tissue, starting to change the signal intensity, and two images are acquired. The inverted, the label and control images, and by subtraction of both, we get the perfusion map. This is a very sensitive technique to patient motion. So the most important is to have a stable patient. But we have the benefit of getting knowledge to the perfusion of the tissue without injecting contrast. This is a case of hyperacute stroke with a diffusion restriction by applying or by performing the arterial. Stop. By performing the arterial spin labeling, we can visualize that there is a penumbra because the area of hypoperfusion here. We perform it in epilepsy protocols as non-contrast enhancing. This is an example of a D knot showing hypoperfusion. So it increases our performance. An example of Moya-Moya disease that was referred for preoperative assessment, showing remarkable collaterals at the basal ganglia. The perfusion study showed the most affected areas within the brain, while the basal ganglia show hyperperfusion because of the significant collaterals, and the left PCA area shows also relative hyperperfusion because of the collaterals. In Moya-Moya, it's important to compare the supratentorial brain to the cerebellum because it's not affected usually in these cases. Another case, application of the K-trans perfusion in head and neck tumor. This is an aggressive orbital lesion showing a very high K-trans value of 0.12, and this case was proved to be rhabdomyosarcoma. Another case with a query, recurrent oral cavity cancer, showing a high K-trans value, and it was proved to be a recurrent tumor. This is a classic form of brain glioma showing a relatively increase in cerebral blood volume reaching up to 4.9, which is very high. Just 1 minute. Another case with CNS lymphoma showing a characteristic finding on the time intensity curve with the washout showing elevated percentage signal recovery, which is characteristic for lymphoma cases. Another case with pathologically proven pilocytic astrocytoma, but it was intraventricular and supratentorial, so it's unusual location. A very characteristic curve was shown with a low cerebral blood volume, yet there is a high recovery. This curve is characteristic for pilocytic astrocytoma. In non-neoplastic lesion, it can show us a low relative cerebral blood volume. Okay. Thus, there are normal values for K-trans, not approved 100%, but can provide us the guide to interpret this technique. Thank you.
Thank you, Dr. Manar, for the nice lecture and very informative. We move now to Dr.